As we begin our 9th virtual training, I want to remind you of a few things. Number one, your job shadowing. You should be sending in, through your student portal, your 8 hours of job shadowing experience. It does not have to be all on one day, doesn't even have to all be in the same office. So you can have multiple sheets uploaded, but you must have at least 8 hours of job shadowing experience uploaded. Without that on your student portal, you will not get any certificates from your instructor. You will not be able to apply for your dental radiographer's license, and you will not get the certificate of completion until this is completed. 2, if you are making payments on your student account, you must pay paid completely in full before you are to receive any of your certificates. Now, if you got a loan to pay for it, the payment arrangements have already been made for you. But if you are on our in-house payment plan, that must be paid in full before you get to graduation. You also must have all of your enrollment records, so your enrollment agreement, your hepatitis B, your TB skin test, high school diploma, and photo need to all be uploaded onto your student portal. Again, you won't get your certifications. We will hold those until you meet all of those requirements. If for some reason you do not do well enough to meet the 105 out of 150 points for the final assessment, if your attendance does not meet the minimum requirements, or if you simply just have not been participating and exhibiting what we expect of our students to graduate, you will not receive your certificates. You at this point would have received some kind of probationary notice, whether it be with attendance or grades. And at that point, you should be on a corrective action plan. If you're following your corrective action plan, then you are on track for graduation. Now, just like every other virtual training, we're going to start with some review. We're going to go back a little while and review some skills that were covered quite a few weeks ago, things that we've been practicing and had in action, but I want to go through for those of you that maybe still aren't feeling 100% confident in all of these skills. The skull, also known as the cranium, consists of 22 bones, which can be subdivided into 8 cranial bones and 14 facial bones. The main function of the bones of the skull is to provide protection and structure. Embryologically, the skull derives from ectodermal neural crest and the mesoderm. These particular early developments start in about the 3rd week of gestation, which means that if there are disturbances during an early part of a pregnancy, there can actually be some permanent lifelong alterations to the development of the skull, to the development of the brain. For example, if during the pre-implantation period, which is very early on in a pregnancy, within the first couple of days before the embryo is actually implanted into the uterine wall, if the meiosis that is occurring, the cell division, is disturbed, it can result in an extra chromosome, which we know as Down syndrome, and can cause developmental and physiological problems down the road. During the embryonic period, if the mother were to contract the rubella virus, this can cause the baby to be deaf or even develop cardiac defects. High levels of radiation can stunt growth, cause mental retardation, or even cell death. And this is also where ingesting alcohol can result in fetal alcohol syndrome. This is a lifelong condition. It can't be cured, but obviously it can be prevented by not consuming alcohol during a pregnancy. It is possible that even small amounts of alcohol consumed during a pregnancy can damage the developing baby. Now, there's an umbrella term. It's like a spectrum disorder where they could have partial fetal alcohol syndrome, where some of the characteristics of fetal alcohol syndrome are present, such as changes to their facial features, but they don't have all of the symptoms of fetal
alcohol syndrome. Alcohol-related neurodevelopmental disorder. People with this disorder experience some or all of the following of impulsiveness, inattentiveness, challenges with judgment and problems with school performance and other issues with law enforcement later down the road. Alcohol-related birth defects are physical birth defects, abnormal changes to the body affecting the heart, eyes, skeletal system, ears, and kidneys. Neurobehavioral disorder associated with the prenatal alcohol exposure is someone that was exposed to more than a small amount of alcohol as a fetus, and they have difficulty with daily tasks like bathing, can struggle in social settings because of significant behavior issues, tantrums, trouble with thinking, and memory. Using some of the most up-to-date information from the Centers for Disease Control, or the CDC, and other scientists, they estimate less than 2 cases of fetal alcohol syndrome a year in every 1,000 live births in the United States. But this could be higher when we think about our patients who may just not feel comfortable talking with their healthcare provider about the fact that they consumed alcohol. And because this is a broad spectrum of conditions, it's possible that it may go undiagnosed. In 2019, CDC researchers actually found that 1 in 9 pregnant people drank alcohol in a 30-day period. The alcohol will pass through the bloodstream to the fetus through the umbilical cord, and the baby can't metabolize or break down the alcohol the same way that an adult does. So it stays in the body for a much longer time and interfere with normal development, particularly the brain and central nervous system. The alcohol can kill cells in different parts of the fetus. It interferes with the way that nerve cells develop and how they travel to form different parts of the brain and their functioning. And obviously, alcohol itself constricts blood vessels, which slows the blood flow to the placenta, causing a shortage of oxygen and nutrients to the developing fetus. Toxic byproducts are produced when the body processes alcohol, and then they can concentrate in the baby's brain cells and cause damage. But this is just one of the many ways that the actual cranium and the brain and just different parts of our patient may be affected in utero before the baby's even born. And then lastly, during the fetal period, if a mother were to be prescribed tetracycline, it is prescribed to treat infections caused by bacteria, including pneumonia and respiratory tract infections, certain skin, eye, lymphatic, intestinal, genital, and urinary system infections, and even other infections that are spread by ticks, lice, mites, and affected animals. So you wouldn't think that it would be harmful, but if a mother were to be prescribed this and ingest it during pregnancy or nursing or during the developmental period of the secondary and primary teeth, so even if a child were to get it prescribed to them when those teeth are developing after birth, it can create tetracycline staining, which ranges anywhere from like a dull-ish gray look to their teeth to a very severe dark gray staining. And because it is something that's internal to the tooth during development, it's not as easily rectified through tooth whitening as if we were considering, tobacco staining is a little bit easier to take care of than a tetracycline stain. In week 12 of a pregnancy, the palate finishes forming inside the mouth, and if that's interrupted, it can result in a cleft palate. These are openings or splits in the roof of the mouth and the lip. We'd consider that a cleft lip. And cleft palate is a common birth condition. It can occur alone or part of a genetic condition or a syndrome. And symptoms are going to arise from the opening in the mouth, including difficulty speaking, feeding. There are surgeries that can restore the normal function with very minimal scarring, and speech therapy afterwards can help correct any kind of speech difficulties post-surgery. So that one can be treated, but we're hoping that doesn't happen in utero. In addition to the bones of the cranium, as a dentist, there are other considerations that need to be taken into knowing the nerves and the muscles of the face, because there are several cranial nerves that are going to branch out into, obviously, the cranium. So you have the olfactory nerve, the optic nerve, the trigeminal nerve. There's all of these different nerves that are running through the bones superficially like laying on top of them. The biggest one that we kind of refer to in dentistry is going to be that trigeminal nerve. The trigeminal nerve is the one that branches down into like the maxillary arch, which is the upper arch of the mouth, so those upper teeth, the mandibular arch, which is the lower arch of the mouth, the lower teeth, into the tongue area, the lips, the cheeks. All the sensation around those is what we're looking at when we discuss that trigeminal nerve. Now, the nerves may provide sensation, but also receptors for information from the muscles to and from the brain. And there are obviously lots of muscles that lay on top of the cranium. They aid in chewing, speech, moving the eyes. There's lots of them that as a dentist that they're going to want to really pay special attention to, knowing where they are so they don't damage them during procedures. Now we have two views of the skull here. We have a lateral view and a frontal or anterior view, which allows you to see the front facial bones that provide the bony support for the eyes and structures of the face. So let's go through some of these bones here. We'll start with what some might call the brain case. The brain case is what contains and protects the brain. The interior space that's almost completely occupied the brain is called the cranial cavity. It's bounded by the rounded top of the skull, or the skull cap, along with the base of the skull, or the floor of the brain case, and it consists of 8 bones. These are the paired parietal and temporal bones, plus the frontal, occipital, sphenoid, and ethmoid bones. When we're looking at the parietal bones, it forms most of the upper lateral side of the skull, and these are paired bones, meaning there's 2 of them, with the right and left parietal bones joining together at the top of the skull. It's bounded anteriorly by the frontal bone, inferiorly by the temporal bone, and posteriorly by the occipital bone. Now, what those terms mean: anteriorly is toward the front, posteriorly is toward the back, inferiorly is below. So when you hear those terms, just kind of picture where they are here on this skull. The temporal bone is what forms the lower lateral side of the skull, or the sides of the skull, and contains the external acoustic meatus, which is the opening to your ear canal. The frontal bone is the single bone that forms the forehead, and at its anterior midline, or the front middle, is between the eyebrows. There's a slight depression called the glabella. The occipital bone is the single bone that forms the posterior or rear skull and posterior base of the cranial cavity. The sphenoid bone is a single complex bone of the central skull, and it serves as a keystone bone because it joins with almost every other bone in the skull. Like if we were putting together a puzzle of the skull, this would serve as like the cornerstone that all of the other puzzle pieces would have to stick to. Another singular bone is the ethmoid bone. It's a midline bone that forms the roof and lateral or side walls of the upper nasal cavity, the upper portion of the nasal septum, and contributes to the medial wall of the orbit, or the eye socket area. You will notice the zygomatic bone, which is purple on the diagram here, connects the temporal bone to the frontal and the maxilla. This is what we would kind of think of when we talk about our cheekbones. And the maxilla and the mandible are going to be those 2 bones that you hear referred to all the time in dentistry, because the maxilla is what contains the maxillary arch, which means the upper arch. So really commit that to brain. Maxilla is the upper bone. Maxillary is the upper arch, or the teeth that are in that upper jaw. Then you have the mandible, which is green here, like a lightish green, and that's going to be your lower jaw. The mandibular arch is all of the teeth that are in that lower jaw, which is the mandible. And this is a hinging bone that rests up into the temporal bone at a joint that we call the TMJ, the temporomandibular joint. There's a joint on the right and the left that connect that lower jaw to the skull, and they are what allows that jaw to slide and rotate in front of each other for speech and eating. I'm sure you've heard people say that they have TMJ, which is for the most part completely true, because everyone should have a temporomandibular joint. But what they are trying to convey is that they have a TMJ disorder, which is a type of disorder of the joint itself, which can cause pain in the jaw when they speak, eat, and it's really different from person to person. It could be as a result of someone who clenches and grinds their teeth. It could be someone that chews. It could be because of an issue post-surgery. But there's a lot of pain and tenderness, aching around the ear, difficulty chewing, facial pain, locking of that joint, making it difficult to open or even close the mouth. Now, there are some less invasive treatments of it where a patient may get like a night guard or even a day guard to wear in their mouth, take anti-inflammatory medications. They can do massage therapy, or there may be more invasive surgical injection type procedures to try and alleviate the pain as a result of the disorder. Now, when you are going through and you're studying this lateral and this frontal view of the skull, please note that this is something we are going to assess you on. We're going to use this diagram with all of the terms removed from it. They'll be labeled with a number, and so you will have to be able to know what each bone is on the skull. It would also be an important thing to note the sutures throughout the skull. The sutures are where the bones have formed and fused together, such as the coronal suture is what connects the parietal bones to the frontal bone on the cranium itself. There are additional structures that we could discuss about the anatomy of the bones of the skull, but what you see here is what we will test you on. It won't be anything additional to this. Every tooth in the adult and pediatric dentition, or the set of teeth that they have very unique structures to them, from a front tooth to a back tooth, but there are some anatomical structures that every tooth will have in common. These 14 items listed here are what you will want to also be studying, because this will also be on your midterm exam, but it is very helpful as you are studying to not only just memorize what number they are on the diagram, because I may change these numbers on you on the exam, but also when you're looking at radiographs and different diagrams, you should be able to take this information and apply it to any other illustration or x-ray that you see, because you've committed the definitions to memory along with where they are on this diagram. So we'll go through these. Number one is pointing at that white, hard outer coating of the tooth. We call that enamel. Enamel which in a lot of layman's terms we may refer to it as gums. Gums are typically really tightly adapted to the tooth. They're soft and spongy. They haven't receded. They don't bleed when you brush and floss. Now, pigmentation can vary from ethnicity to ethnicity, but it's usually a nice pink color. It's not typically, you're not going to see it fire engine red. That would be an indication that there is some inflammation and infection. Number 4 is the cemento enamel junction, which you may also see referred to as the CEJ. This is just a big long word to describe that at some point the protective layer of the crown, which is the enamel, is going to meet up with the protective layer of the root, which is cementum. We haven't gone over that yet. That's number 6. Meets, just like a junction, an intersection on the road where two roads meet. This is where the cementum and enamel meet. This is what we would a lot of times refer to as the neck of the tooth. Number 5 is the pulp cavity, and this is referring to the entire internal portion of the tooth where it's completely hollow. Containing the nerves and blood supply that help to keep the teeth alive. It's imperative that we catch decay or caries, for the more technical term, prior to getting to this pulp cavity, because once it enters into the pulp cavity, then the nerve has been infected and we do have to do a root canal. So as decay progresses, it starts in the enamel, in what we call incipient caries, where the enamel starts to just become demineralized, which the good thing is if we catch that soon enough and we up our dental hygiene practices, usually we can stop or arrest that decay. As it continues to spread, we call it a frank lesion. So it gets larger, it works its way through the enamel, which takes usually a little bit of time. It gets into the dentin and it spreads a little bit faster. Obviously, it's not as dense as the enamel, and then it works its way to that pulp cavity, and that's then when we have issues with those root canals. There's no way we can do a filling on that tooth. They either need an extraction where we remove the tooth, or we have to completely clean out that infected nerve tissue through the process of a root canal. Number 6 is your cementum, which is the calcified connective tissue that covers the root of the tooth, which is what number 11 is. If you think roots of a tree are in the ground, the roots of a tooth are in the bone, and so the cementum is what covers that and provides structure for the periodontal ligament, which is number 7, to actually attach to. And it has similar structures. So the cementum has similar structures physically, chemically, to that of bone. Is the protective outer covering of your tooth. It protects the crown, which is what number 12 is on the diagram, and it is going to be the hardest substance in the body. This has a really sensitive tissue inside of it, mineralized, and helps to protect the nerve of the tooth from decay and the changes in pH and acidity levels as we eat and drink throughout the day. Number 2 is dentin. This is a yellowish and somewhat elastic but mineralized avascular tissue that helps to support the enamel and encloses the pulp chamber, so it makes up the bulk of the tooth. Number 3 is your gingiva. Number 7 is that periodontal ligament. The ligament is what is attaching the cementum to the alveolar bone, which is number 8, which is the cancellous, more spongy looking, less dense bone than what you'd find in your femur. It's a different type of bone. So the alveolar bone is what the tooth is embedded into. The ligament, number 7, is what attaches the tooth to that bone. So it's not just sitting in there. It does have fibers that are attaching it to the bone. It not only attaches it to it, but it also kind of acts like a shock absorber. When you think about it, there's that buffer area that when you bite together, your teeth have some give to it, so it's not just cementum hitting against alveolar bone. And if you were to take your tooth right now, you'll notice that there's a little bit of give or a little bit of play to the tooth. You're feeling the give that that ligament has around the tooth in the socket. Again, alveolar bone is what we call a cancellous bone. a cancellous bone versus a compact bone is that the bone cells themselves aren't as tightly compacted, so they're not going to be as dense as like you would find in different areas of the body where you have compact bone, like in your femur. Number 9 is the radicular pulp. The radicular pulp is not just that one particular point that it's pointing at. Think of it as all of the nerve vessels that are passing through the root. So that's the portion of the pulp that is in the root, which is the portion of the tooth and the bone of the structure. So you can also remember it as the R in radicular is going to match up with the R in root. Number 10 is the apical foramen. If we break down that word, apical means, or is referring to apex, which is the tip of the tooth. Foramen is an opening for nerves and blood vessels to pass through. So in this case, it's an opening at the apex, or the tip of the tooth, where the nerves and blood vessels go up and out of the tooth. So we have to have that entry point. You can have accessory canals, extra little openings that go out of different areas through the radicular pulp and out the sides of the root. Those can become problematic if the tooth were to become infected. We'd have to make sure that we clean out those accessory canals effectively, or else the tooth will just become reinfected. 11 is the root, portion of the tooth embedded in the bone. 12 is the crown, the portion of the tooth that is covered in enamel. And 13 is going to be the coronal pulp. So again, not just that one like spot it's pointing to, but all that pulp area that's resting inside of the crown. Just like in radicular pulp, the R matched up with the root. In this case, crown and coronal pulp both start with C. So the coronal pulp is in the crown of the tooth. And last but not least on this diagram is number 14, the pulp horns, which are the projections at the top of the coronal pulp.
We're going to take a look at the different surfaces of the teeth today. This way we can better understand when we're communicating with insurance and other dental professionals what surfaces need to be worked on. Your front 6 teeth from cuspid to cuspid are considered your anterior teeth, and that's for the maxillary and mandibular. And premolar to molar are your posterior teeth. As a review, naming them from the midline out, you have your central incisors, lateral incisor, cuspid, first premolar or bicuspid, second premolar, first molar, second molar, and lastly our third molar. When we're chewing, our anterior teeth have what's called the incisal edge, that's that sharp cutting edge, and the posterior teeth have a flat chewing surface called the occlusal surface. To better identify, I'm going to use a little bit of colored dough here, and I'm going to place it onto first the occlusal surface of those posterior teeth. Think of this when you're eating those chewy Swedish fish where your candy gets stuck. That helps us to grind up our food for better swallowing. For our anterior teeth, the anterior teeth have that sharp cutting edge on the edge of it. This is kind of like our scissors of our mouth. When we want to bite into our apple or into our meat, we use the incisal edge. On our anterior teeth, there is the front surface that you'll see when a patient were to smile. We call this the facial surface. This is the surface on any anteriors from cuspid to cuspid. When we move to the posterior teeth, there's different terminology for that same surface. It's called the buccal surface. It's near your cheeks. That's what it's resting against. For all of your mandibular teeth, on the portion where your tongue rests, it's called the lingual surface. That's going to be on all of your anteriors, on that tongue side, and it would even apply to those posterior teeth on the tongue side too. Now this is almost a universal term. We use lingual for both the maxillary and mandibular arch, although you may occasionally hear palatal for that maxillary arch. The interproximals are where it gets tricky. Think of the interproximals as when you're flossing that space between the teeth. One surface is going to be closer to the midline, one is going to be further away. So as you floss and you hug that floss to the tooth, for example, this side of the tooth is further from the midline on that molar. It would be the distal. And then we're going to floss. We're going to hug the distal of that premolar. And then we're going to hug the mesial of the molar. There's a mesial and a distal that touch each other. And this has all to do with in relation to that midline. When we're looking at the mouth, you have what's called your midline or your mid-sagittal plane, and that's what splits our body into our right and our left, and that's right between your central incisors. On every single tooth, you have a mesial and a distal surface. Mesial meaning towards the midline, distal meaning away from the midline. So as we're looking at each of these teeth, I've starred the mesials of one side of the mouth in pink and the distals on the other side in a blue star. Now there obviously would be a pink and a blue on each of these teeth, but to keep it kind of simple, we've only split it into halves. So as you look at the molars on the patient's right, which would be the left side of your screen here, those pink stars are the mesial surfaces. Now this isn't the surface that you see from the top. These would be the occlusal and incisal edges that you see. These are the surfaces that are interproximal. So as you're flossing, that tight area, that contact point, and when you're down into the embrasure space, that free area past the contact point, these are the interproximals. So you have your mesial towards the midline and distal away from the midline. This has got to be one of the more confusing ones to think about because it's not as simple as just looking at that flat chewing surface or the outside surface towards the cheek. So this will take some practice, but really understanding terminology that mesials towards the midline, distals away from the midline, buccals against the cheek on a posterior tooth, incisals against the lips of an anterior tooth. Facials on the lips of the anterior teeth. Incisal is the sharp cutting edge of the anterior teeth, whereas occlusal is the flat chewing surface of those posterior teeth. Keep practicing this terminology as this is something that you will have throughout your whole career as a dental professional.
We will begin this week discussing the adult dentition, and next week we'll move into the pediatric or the child dentition, which are the teeth that are present normally anatomically in the adult or child mouth. There are some different ways that we can name or identify the teeth that are present in the adult mouth. And so what is super helpful in getting this information committed to memory is to color code. So pull out this sheet out of your workbook. If you don't have that already, you can download this file or you can come back to this and color code it. Just take a screenshot or a photo of this and color code when you do get the physical copy of this. But we are going to start off with some terminology that's really important, going to make it a lot easier for you to learn this information. We already talked about the maxillary arch being the upper jaw and the mandibular arch being the lower jaw. When we talk about the midline or the mid-sagittal plane, that is the imaginary plane that goes right down the center of the human body and splits us into our right and our left. Now, if you're looking at the screen, you'll notice that on the right side of the image, it says left, and on the left side of the image, it says right. This is transposed because the idea is that you are looking into intraorally the patient's mouth as though they were sitting right in front of you. So it will be the patient's right and the patient's left. This will be the case anytime that you're looking at a paper chart, a computerized chart, x-rays or radiographs on a screen. Anything that's on the right side of the screen is truly the patient's left, and everything on the left side is the patient's right. We'll start with their names. We'll start right at the midline, which is that middle line, that dotted line that goes right down the center, splitting them from the left to the right. And we're going to start with what we call our anterior teeth, or our teeth that are toward the front of the mouth. Labeled in red are our central incisors. Incise means to cut, and so these anterior teeth have that sharp incisal edge, the edge of the tooth that you would use for cutting into food, and they are centrally located. They're right at the center of the midline. These are single-rooted teeth, so if we look at them at an x-ray or when they've been removed through an extraction, you're going to see one single root for this particular tooth. The upper arch, or the maxillary arch, versus the mandibular arch, those central incisors are going to be larger in their shape and size than the mandibular central incisors, but they do have the same names. So your ones on the top and the ones on the bottom in red are your central incisors. Right next door to those, labeled in yellow, are going to be your lateral incisor. Lateral meaning to the side. Incisor, this one still has the same function as the central incisor, so it's for that cutting. It's got that sharp cutting edge, the incisal edge of the tooth. And these are also single-rooted, but they are slightly smaller, slightly different in their shape than the central incisor. So if you look in the mirror and you're looking at those two front teeth, and usually we're going to see those maxillary ones because they do overlap the mandibular ones. But we're looking at those two teeth right in the midline. Those central incisors are big, square, blocky shaped. Then the ones right next to them, the lateral incisors, kind of look like that tooth but shrunk down a little bit. And then the last anterior tooth, meaning tooth towards the front, is going to be your cuspid. Those three types of teeth, the central incisor, the lateral incisor, the cuspid, are all single-rooted teeth that make up the anterior teeth. You have the same on the maxillary as you do on the mandibular, assuming none are missing or have been removed, which are labeled in blue. Cuspids have an interchangeable term of canine, so you may hear it referred to as a cuspid or a canine. This is that tooth that has that sharp point. People call them their eye tooth, their dog tooth, but when we're referring to it in class, it will either be cuspid or canine, and canine like the animal, not the letter K and the number 9. Now we're going to move into the posterior teeth. Posterior meaning towards the back, and so these teeth do have a distinctly different function if you were to look at them in the mirror or even run your tongue across them. The anterior teeth have that incisal edge for cutting, and then when it's time to chew, you would use your tongue and cheek muscles to move that food to the back to masticate or chew on what we call. As far as eruption period, or when the teeth actually break through the gum tissue and start to work their way into the oral cavity or the mouth, it does vary from person to person, but the average years of age that the permanent teeth, the adult teeth, come in. For central incisors, it can be anywhere from 6 to 8 years of age, depending on if it's a maxillary or a mandibular central incisor. For a lateral, we're looking at about 7 to 9 years of age. For your cuspids, we're looking at 9 to 13 years of age. Our first bicuspid is about 10 to 12 years of age. Second bicuspid, 11 to 13. First molar, 6 to 7. second molar 12 to 14, and then that third molar significantly later, 17 to 21 to 25 years of age. A lot of times we'll refer to our first molar as the 6-year molar and the second molar as the 12-year molar, because those are the average ages that you're going to see these teeth erupting or moving into their functional position in the mouth. Called the occlusal surface. If you run your tongue across the flat chewing surface of those back teeth, you'll notice that there's grooves, pits, and fissures, things where food and candy get stuck down into, and you really got to scrub them clean real well. Those are going to be your posterior teeth. In utero, teeth do start to be formed around week 5 to 6, and then they will begin the eruption process around 4 months after birth. But again, we'll go over that a lot more detail next week when we get into the pediatrics. When we have the permanent teeth beginning to form and the primary teeth roots are being destroyed, it's a process of what we call resorption. Then the permanent teeth cause the primary teeth to fall out or exfoliate. And then lastly, these permanent teeth move in and erupt. So you'll hear those terms utilized a lot in your offices. Continue to study this information as you will utilize this terminology from day one in class all the way through the rest of your career. Like, this terminology for the names of the teeth will never change. Now, numbering systems. We're going to change gear for just a moment because there is the naming system that we went through that's going to go from the midline back, but then when we utilize numbers, this naming system starts from the posterior and works its way from the most posterior upper right quadrant meaning a fourth of the mouth. So if we're looking at the maxillary right furthest back tooth, it's going to be a third molar, but we call that tooth number 1 in what we call the universal numbering system. This is also known as the American system. It's a dental notation system commonly used here in the United States. And other than the Palmer notation system, which we'll talk about when we get into orthodontics, this is what you're going to also hear use. So it's kind of interchangeable. What it does is it kind of simplifies what you're saying. So instead of me saying the maxillary right third molar, which is a lot of wording, a lot of writing, I can just say tooth number 1, and it's meaning the same thing. So if you were to put your finger in your upper right quadrant, if you were the patient, now it's going to be opposite of what you're looking at on the screen, because this is as if I were your patient and you were looking into my mouth. I'm going to be pointing at my upper right. And if my third molar is there, that would be tooth number 1. We would work successively up towards the midline to tooth numbers 8 and 9, which are the central incisors. Then swing back around to the maxillary left or the upper left. Third molar known as tooth number 16. So 1 and 16 a lot of times are missing because they're impacted or have been removed. But that does not mean that your second molars, the purple teeth here, then become tooth numbers 1 and 16, because that would get really confusing when there's multiple patients with all these different missing teeth. It would throw off your numbering system. Tooth number 1 is always the maxillary right third molar. If it's missing, then it's missing. We skip it. We jump to tooth number 2. If number 3 is missing, we just say number 3 is missing. We skip that in the numbering system. Even if through orthodontics, which is braces, if the gap where the tooth was has been closed, we aren't going to be renaming. Like, those don't change anatomically. So upper right, number 1, upper left, 16, drop down to your lower or mandibular left. That would be 17. Up to the midline on the mandibular arch or the lower arch, that's 24 and 25, those red central incisors. And then all the way to the mandibular right, your lower right or the patient's lower right, tooth number 32. So you want to know either of these. Be able to communicate whether it's through the naming system of first bicuspid, second molar, maxillary right, maxillary left, mandibular right, mandibular left, or even just as specific of saying tooth number 20. Let's do some practice here. So if I were the doctor and I said, please take an x-ray, or we're going to take a look at tooth number 14 in your mouth, try to point where 14 is about, You can even be more specific and find exactly which one it is. But let's describe tooth number 14. You can look at the screen there. Tooth number 14 is going to be in the maxillary arch, so you should be pointing on an upper tooth. It will be the left, so even though it's on the right side of the screen, it's the patient's left, and it's a first molar labeled in black there. Let's go for another one. Describe tooth number 31 for me. 31 is going to be your mandibular right second molar. It's that purple tooth. Last one, and you're welcome to pause it as we're doing these. Tooth number 23. Tooth number 23 is going to be the mandibular left lateral incisor in yellow. You have what are called bicuspids or premolars. Again, another interchangeable term here. If you think of the word bicuspid, bi meaning two, cusp meaning point, so you've got 2 points to these teeth. Whereas if we were to look at a molar, they're significantly larger in their shape, and we're looking at more around our 4 and 5 points on them. But you do have a first bicuspid or premolar meaning before the molars. That is labeled in green. Then you have a second bicuspid or premolar that is labeled in brown. And if you were to run your tongue on those, you can feel the 2 points and go back one more, and you feel that tooth is significantly larger. And it may even have an extra little cusp, a little point on the tongue side of the tooth or the lingual surface. We call that the cusp of Carabelli. Doesn't really mean anything. It's just an extra anomaly that we see on some people's teeth and others not. On that first molar labeled in black there. So if on the lingual you have an extra little sharp point on that first molar, you more than likely have a cusp of Carabelli present. These are going to be the largest of the 3 molars, and they get smaller as they move more posteriorly or more towards the back of the mouth. You get your second molars in the purple and your third molars in the orange, which is what we traditionally think of as wisdom teeth, and they usually are impacted. Even though this tooth doesn't have a flat cutting surface like the central and lateral incisor, it does have an incisal edge. It just comes to more of a point. Now, there are some people who have had these removed, congenitally missing, so they just never developed, and really that can be any tooth can be congenitally missing. It can come and erupt in the improper position, so it may be somewhere it shouldn't be, it may be impacted. There's a lot of reasons why that might not be there. So we do want to kind of get used to what they look structurally, so that missing teeth, patients that have teeth removed for orthodontics and then the spacing has been closed up, or the pediatric dentition where there's a mixture between the adult and the pediatric, we call that the mixed dentition period because they've got both. If you're trying to practice on a patient at home or family member, that's where, as a new dental assistant, it can get a little confusing. And so using this diagram, using the 3D models in class, and then someone who you're fairly confident that they have all the teeth there is a great way to practice this information. One thing that we'll be doing in our first clinicals is we will be examining the teeth one by one. We'll be naming them, we'll be numbering them, so we'll be getting accustomed to using this terminology, but also viewing it clinically inside of a patient's mouth. When we're looking at a patient's mouth and it's missing, we can quickly identify that. It is single-rooted, usually comes to a point, that cusp on the tip of it, although some people, they clench, they grind, and it's been worn down, and it's a little bit more flat in its structure on the tip than what you would see other cuspids. Next week, we'll cover the pediatric or the primary teeth, what ages we might see those start to erupt, and when we see those exfoliate or they fall out of the mouth, that's when the adult teeth erupt and work their way into the oral cavity. Every day when entering into the office, you will turn on your vacuum and your compressor first thing. Then fill your ultrasonic with water and an enzyme tablet. You will refill your autoclave with distilled water.
And weekly, you'll want to make sure that you run a biological monitoring strip inside of the autoclave itself. You can just run it on a regular test cycle, return it to the envelope, seal it, and make sure that you have put on your labels or filled out the information. Whenever you notice that your suction is becoming lessened or clogged or just once a week maintenance, you should make sure that you're changing out your gentle traps. You can locate those typically in the units. You'll get a new one and replace it each week. Now that you've gotten everything set up and ready to go for your day, you can set up for your patient. Begin by making sure that your hands have been properly cleaned, either using soap and water or a hand sanitizer that utilizes a 70% or higher alcohol concentration. After you've washed your hands, make sure that you're not touching any contaminated cabinets like your trash can cabinet. You can get out your tray cover and barriers for the room. And the order really doesn't matter here, honestly. Just come up with a rhythm and a system so that you don't forget the different steps of setting up your room. If your room doesn't use an overhead light, maybe they have lights hooked to their loops or ones that are hands-free. You don't have to put the barrier tape on, but you can see a little trick here to make it easier to remove. After the tape, you can see here that I'm going to go ahead and put the headrest cover on. We have half chair sleeves. There are ones that are smaller that you might see in the hygiene setting where it just covers the headrest, or a full chair sleeve in a more surgical setting. I like to then go ahead and set up the procedure items, all the instruments, hand pieces, and small items on the tray itself. A general setup is going to be your HVE, placing it into the larger of the sections, making sure that the beveled end that has the hole is facing out and that the levers are shut off so that it's not continually suctioning while you're working with it. This saliva ejector, which we use for the smaller amounts of fluid, we're going to put into the smaller section that has the rubber fitting and bend it like a candy cane so it's easier to place into the patient's mouth. Next, we're going to place our high-speed handpiece onto the unit lines, making sure to line up all of the small tubes and screw it into place. Now this may vary from office to office how your handpiece actually connects to your lines. Our contra angle or slow angle attachment simply pops right onto the motor itself. Now each of these motors you do want to take special caution not to send through your ultrasonic. You are going to want to make sure that they are handled and disinfected properly. The rheostat on the floor there, typically there is an on and off switch for the water. You would have it on for your high-speed handpiece and off for the slow-speed handpiece. Next you'll see that I'm placing out our bibbies, our instruments. This one so happens to be a basic kit that is closed and sterile, but once we open it is no longer sterile. But we're going to set this out in preparation for our patient. And I like to set these out in the order that we're going to use them too. We'll take our air water syringe tip. We're going to use a metal one that can be sterilized and reused. There are ones that are disposable. Use our thumb to press in that outer metal ring of the syringe and place in the tapered point of that syringe tip. And you've got the two buttons for the air and the water independently, but when you push them together, you're going to get a nice power washer, which is great for rinsing off stuck-on objects. After you have set up your room, you can go get your patient from the reception area, making sure that you follow all of HIPAA protocols. Seat your patient, making sure it's at the proper height. Update your patient's medical history and place that bib. And I always get the question, do we have to have our PPEs on at this point? No, we do not, and actually we don't need to be leaving the room with those on. We're going to take their blood pressure prior to any appointment, and then when it's time to start working, we're going to don our PPEs, our personal protective equipment. I like to put them on from head down. So our eyewear, our mask, making sure that we're putting it on properly, bending it at the nose, placing it over your ears, without looping them. When you loop them, what happens is you actually get like this bunch on the side of it, and pull it down under your chin and fold it around your nose. So you've got your eyewear, your mask, and your gloves last. Now the gloves are really important that you have ones that fit and function, so make sure you're wearing the proper size gloves. If they're too big, then you lose dexterity, and if they're too small, they can rip really easily. So eye, mask, gloves last. We're skipping a few steps here because every procedure is pretty independent on what you need set out for it, and we're going to learn that as we go through the course. And depending on if it's a recall, which is a hygiene or a dental cleaning appointment, they're not going to need numbed, so we're not going to have to do the topical anesthetic. But let's walk you through some of these common chairside things. Topical anesthetic is used on a cotton-tipped applicator placed in the area of the injection site, which we'll cover when we get into the syringes and anesthetics. But you saw a maxillary placement and a mandibular placement, and I like to leave it in the mouth until the dentist comes back in so they can see that I've already placed it. So if you want to use high speed and just place it in each quadrant slowly, you can turn towards the During most of your dental procedures, from crowns to fillings, you are going to utilize the HVE, the high volume evacuator. That's that larger suction. I think of it as like your shop vac. It's going to get lots of water spray. It's going to cut down on the aerosol, any chunks or bits that are going to fall out of that tooth. That is going to be right up against where you are working to help pull those things away. You can use your saliva ejector throughout the procedure too, just to make sure that you're getting any buildup of that moisture out of the patient's mouth so they are more comfortable. As you see here, your doctor is working in the patient's maxillary right, so we will be positioned in the patient's maxillary right, but on the lingual surface. It doesn't matter if the doctor is working on the lingual, you do not cross over to the opposite side of that tooth onto the doctor's side, because you will block their line of sight. Now we are on to those maxillary anteriors and showing two different positions for the HV depending on where the handpiece is placed. If they're working from the lingual and the water spray is coming out of the mouth, then you will want to place the HV on the facial. But if they are working on the facial and the water spray is going into the mouth, you'll place it on the lingual. Notice how we're pulling back that HV and using it as a retraction item to pull back the cheek. We will be on the buccal for the maxillary left. Same with the mandibular or the lower left. We're going to use that to pull back the cheek. Do not cross over to the doctor's side of the tooth, because you are again going to block their line of sight and they're not going to be able to see what they're doing. Now, if the doctor's not in the patient's mouth, that rule really doesn't apply. You can rinse and suction to your heart's desire wherever you need to be. On the patient's mandibular right, this is where you kind of have to work with the patient's tongue, retracting it, pulling out of the way, because you will be positioned on the lingual surface. If you are ever working on the mandibular anteriors, here is a view from us suctioning from the lingual.
Not that you're usually good. Do you need your pupping? Do you want me to hold
A lot
it?
of times you're going to have your air water syringe and your HVE in the patient's mouth simultaneously. They do a lot of times come out together. Let's take a different view here, a little bit more up close and personal. We're back on the patient's mandibular right, and if you are ever working with a doctor and they're working on the same side that your suction is meant to be placed on, you can just move a tooth or two more posteriorly, so more towards the back of the mouth, so that all that water spray will be collected in the way that gravity would pull it. We can see the patient's mandibular left. We're using that HVE to pull back the cheek out of the patient's way, out of the doctor's way. Same here on the maxillary left. Key is maintaining a clear field of view for that doctor and keeping the patient comfortable. We don't want to see a lot of fluid building up. That would be really uncomfortable. That's where you can grab that saliva ejector and stick it into the corners of the mouth. Being careful not to hit the back of the tongue, the roof of the mouth towards that soft palate, or really just way in the back of the mouth where that uvula would be. We don't want to get that far back. That would be really uncomfortable and can cause our patients to gag and worse, get sick. I don't know about you, but I don't really want to clean that up. Maxillary right, we're on the lingual surfaces here. Some things to note as you watch this again is to make sure that you don't turn on the HVE right in the patient's ear, as it can be really loud and startling to a patient. Try to turn it on slowly and away from their ear, and don't leave it sitting running the entirety of the procedure. We're rinsing, we're suctioning as we're going through the patient's mouth here. Next, let's take a look how we would rinse and suction utilizing the saliva ejector, which you're only going to really need if the doctor's not working. The saliva ejector will not be sufficient enough if the doctor's working with the high-speed handpiece. Unlike the HV, they can close their lips around that saliva ejector. Now let's take a look at a slowed-down version of transferring instruments to our doctor. Typically, the mouth mirror and the Explorer will be transferred to the doctor simultaneously, with the mouth mirror going into their non-dominant hand and the Explorer into their dominant hand, so they can go into the patient's mouth and start working. When receiving the old instrument, you will grab with your pinky and drop the new instrument down into the doctor's hand in the position of use, meaning if it's a maxillary tooth, have it pointing up, mandibular tooth pointing down, and the end that the doctor has requested. Transferring and placing cottons is something that a dental assistant will do on the daily. When transferring a cotton roll, it's best to transfer it already placed into the cotton pliers. I like to pinch the end that's holding the cotton roll so that they can more easily go into the patient's mouth. Have extra cottons on hand just below the patient's chin in what we call the transfer zone, so the doctor can place for the procedure that they're going to be performing. Here you will see a maxillary cotton roll placement onto the buccal surface of the patient's mouth. Now typically when you're removing this, unless it is saturated with water or saliva, you will want to get it wet so it doesn't stick to the patient's tissues and kind of tug and leave cotton stuck behind. For a mandibular placement, you will place a cotton roll on the buccal surface and the lingual surface just underneath that tongue, being careful not to hurt that soft tissue below it. Notice how the assistant's hand is remaining underneath the chin to receive the instruments that are no longer needed. When the doctor is removing the cottons or any material from the patient's mouth, you'll want to make sure that you have your hands handy so you can receive those items and return them back to the tray behind the patient. Next, we'll see how the dry angle is placed, and they can be placed independently of the cotton rolls or with the cotton rolls for extra isolation of the field that you're working in. The doctor will bend the dry angle, place it into the buccal surface of the patient's cheek. And this is also where it's really important that when it's dry, it likes to stick to the tissue. You want to get it wet so that you don't leave any cotton behind. It doesn't have any discomfort with tugging and pulling of the tissues. At the completion of a lot of procedures, you are going to want to check the bite utilizing articulating paper and Miller forceps, where the patient will chomp, chomp, slide around, and it will leave markings on the teeth to determine if any adjustments need to be made. Once finished, you can dismiss your patient, and depending on how your office runs, you may dismiss them and have them walk to the front of the office with a routing slip, or you will bring them up and talk to the front desk about what was completed that day. When breaking down the room, you want to make sure that you transfer all dirty instruments in a non-puncturable container to sterilization, and place those instruments into your ultrasonic, closing the lid and turning it on, allowing it to process through. Now, because you'll want to leave it in there for about 90 seconds or so, you'll want to take that time to go into your room and wipe everything down, following the instructions of the specific materials that you are using, being careful and mindful to have gloves on while you are cleaning that room. After your room is clean, then you can come back with your dirty gloves or clean gloves, just as long as you have gloves on, removing your instruments from the non-running ultrasonic, allowing any of the extra liquid to drip back into the ultrasonic, and rinsing them off. Your office may have you dry them prior to putting them into a sterilization pouch. Be careful when handling instruments, because this is where you can accidentally get stuck. No needles should be transported to your ultrasonic. Needles and any of those sharps should be disposed of in your room into a sharps container. Dump out the instruments carefully into your hand, placing it into the properly sized sterilization pouch. Now, your office may use a different system for bagging or putting them in a cassette, so you want to make sure that you are adaptable and flexible to learn how your office does things. Place it into the pre-opened sleeve. Peel back the sticky tab and fold it over. Now, this bag is not sterile. This needs to go into the autoclave and be sterilized. You'll be able to know whether or not this has been sterilized by looking at the packaging and seeing whether or not that the little monitor has changed colors. And you can see here we have different sizes for different purposes. One way that I like to process my burrs is to put them in a tea diffuser. It's a great way to keep them together, but I don't run that through the autoclave. That seems to keep the moisture and they tend to get a little rusted. At the end of your day, what you'll want to make sure that you do is you're draining and cleaning out the ultrasonic. Typically there is a drain plug or a switch that allows that to drain into a sink, and then you will remove any of the cassettes or any items that are in it, scrub it clean, because it does get a film, a biofilm on it that we want to make sure that we're cleaning. This can be drained and swapped out anytime that it becomes overly soiled throughout the day. So if you were to put extraction instruments in here and that liquid become overly soiled, then you would want to drain it and put in a new liquid and enzyme tablet. Place your instruments into the autoclave, making sure that you don't touch the front of the door with any kind of dirty gloves, because the other staff members may be touching it with ungloved hands. And there's this big debate on whether or not it should be paper or plastic side up. I find that paper side up dries better. The biggest thing is just to make sure that you're not stacking any of the bags on top of each other while you're working, because that will prevent it from drying properly. Close and latch the door once it is full, making sure that you do have the water properly filled up. Choose the correct settings, whether it's unwrapped, wrapped, or hand pieces and let it run. Make sure that when it's completed, you allow it to go through the full dry cycle. And now that you're completely done, if you need to doff your PPEs, make sure that you're doing properly so that you do not contaminate yourself or anything around you. Remove your mask and your gloves. Wash your hands and eyewear. When a patient becomes established in your office, we will not only look at the restorations that are already there, but determine whether or not the patient is in need of any treatment. Each time that the patient comes in, the doctor is going to perform an exam to make sure that there is or is not something that needs to be addressed. And this is where treatment planning comes into play. This is not just something that the front desk does. In a lot of offices, the clinical assistant does go over treatment with the patient on what needs to be done, how the procedure is ran, and sometimes even the cost and how their insurance benefits might work in these particular scenarios. And while you may not be interested in being a front office staff member, there are times that you want to be cross-trained so you have a better understanding of what's happening with your patient's care. We do have some papers in our workbook that go along with this next section. So once you jump onto that video, then you can pause, flip open to those pages, and follow along with it because there is a little bit of math. Don't worry, the beauty of it is it's going to be simple, and majority of the time your computer handles it for you anyways. But when we do it by hand, it's going to make better sense as to what's really happening here. Upon selection of your patient in the Open Dental software, you can go to their clinical chart by clicking on the tooth icon on the left. This is where you're going to see a visual representation of things that have been completed by us in blue, completed by other providers in green, so they came in and this was already done, and treatment that we are recommending them to have done in red. So you've got fillings and extractions, and you'll notice that their extractions here are using an X icon, whereas we've been using circles and lines. Nobody's doing it wrong in this situation. It's just this is how the software was set up. How you would input the treatment is you would click on the tooth that you want the treatment applied to, and it will highlight its number. And then you'll go to the right side and you'll see quick buttons where it's got some commonly used procedures, or you can click on the procedure list button. That's going to pull up the whole list of ADA codes that break down into different categories what procedure you want that tooth to have done on it. After you click it, it's going to automatically put it onto there. It's also going to put it in the default view description progress note area of the chart. This is actually where you will put a patient's progress notes. You'll right click the procedure you did that day that's listed there on the screen, and there'll be a section to add notes. You can set up what are called quick notes, where it'll ask you questions like what was the tooth number, what were the tooth surfaces, and you check boxes, and then it auto-populates your progress notes for you, and then you can change and customize it once it's done if you need to.
You also have a quick view of the patient's medical history here, medications, significant health history, things like allergies are going to be listed in that patient information section. In the Open Dental software, there is a section specifically for your treatment plan. When it's added in the chart section, which is the icon with the tooth, you'll see a visual representation of treatment that's already been completed, what needs to be done, the progress notes, all those things are there. But the treatment plan section is going to break it down in the financial side of things. You can create priorities and determine that these things should be done first, and then second, and then third. It'll tell us what teeth numbers and surfaces we're working with and the ADA codes associated with that. It'll also have the description and breaks it down for our patients. The first column is our office fee. What do we charge for that? The allowed amount is a negotiated amount. If you're an in-network provider, this is going to drop that amount down. Then we have our primary insurance, and we're estimating. I always emphasize that when I speak, that this is your insurance estimate, because I don't want to guarantee or promise something and then the insurance company not follow through with that, and then I look like I was being the one that was dishonest. So I say, this is what I estimate your insurance to pay. If they have secondary insurance, it'll calculate it in there too. If it's an in-network provider, it will have a discount section, and then the patient portion is calculated on the far right. You can see the columns on the bottom right that have the annual maximum and deductible in there. It keeps track of how much is being used, at least in our office. This would have to be manually updated if they went, say, to an oral surgeon or a endodontist. They all still pull from the exact same maximum we are. At the top, you can save the treatment plan and then print it off, go over it with the patient, have them sign it. That way, you can scan it into their chart and you have proof that you went over it. So if they were to not follow through with treatment and something big arises because they didn't, they can't come back after the practice. If you perform treatment and they decide that you never told them how much it was going to cost, you can pull this document up and show to them that they were made aware of it and they agreed to the terms. It's also really helpful too, as the patient, to have something to go back to and refer to if we didn't schedule the day of and we wanted to go home and think about the financial side of it, because there are things in dentistry that are really expensive and a patient's just not able to commit to treatment right off the bat. They need to go home and figure out how or if this is something that they can take care of financially.
There is a card that they can sign up for. It's called Care Credit. Care Credit is a credit card that is specifically designed to be used in the medical setting, so it's not something they can go on a shopping spree with. That money can only be used at a medical or dental office. When you're notating on a clinical record, like you see here, blue typically indicates completed treatment by our provider. The red indicates treatment that needs to be done. Sometimes you are also notating watches on patients where it seems like demineralization has begun, but the tooth is not severe enough to warrant a filling. Let's take a moment. You can pause the video if you want, and I want you to take a look at this clinical record here and see what has been completed on this treatment. You can jot it down. All right, let's go through this together. Tooth number 1, what does tooth number 1, 16, 17, and 32 have had completed? This is a surgical extraction that has been completed on these teeth. Number 3. Number 3 and number 15 have both had sealants completed by our provider. Number 6. Now, number 6 is not treatment that's completed. This one is actually treatment that is planned. This is the incisal facial lingual filling. So you'll notice it's on the incisal edge of both the facial and lingual surfaces, indicating it's all one solid restoration. If I were to say incisal facial and a separate lingual, you might see a dot on the lingual surface where it might be indicating that it's a completely separate filling. It's not connected. It's going to require a separate prepared area of the tooth. Number 11. Number 11 needs a class 5 lingual restoration. Number 13. Number 13 needs an occlusal filling. What about number 14? What has 14 had completed? That's going to be your simple extraction, the simple line. And lastly, 19 has an occlusal filling completed. Pull out those handy clinical charts you've got because we're going to do some practice. Our big topics for the week are specialties of the periodontics and endodontics offices. The area of periodontics, deriving from the Greek word peri, around, or odis, tooth, is the specialty of dentistry that studies the supporting structures of the teeth along with the diseases and conditions that affect them. These supporting structures are known as the periodontium. It's used to describe the group of structures that directly surround, support, and protect the teeth, and is largely composed of the gingival tissue and supporting bone. Your normal healthy gingiva are going to definitely range in color from light pink to heavily pigmented, depending on a lot of times patients' ethnic background and genetic factors. The soft tissues that surround and protect the underlying cementum are going to be the periodontal ligament and alveolar bone. The gingiva is categorized into 3 anatomical groups: the free, attached, and interdental gingiva. Each of them are biologically different, but they're all specifically designed to help protect against mechanical and bacterial destruction. What the free gingiva is tissue that sits above the alveolar bone and are considered to be the free gingiva. In a healthy periodontium, the gingival margin is the fibrous tissue that encompasses the cemento-enamel junction, which is the line around the circumference of the tooth where the enamel of the crown meets the outer cementum layer of the root. A natural space called the gingival sulcus lies apically to the gingival margin between the tooth and the free gingiva. The attached gingiva, the junctional epithelium,
is a collar-like band that lies at the base of the gingival sulcus and surrounds the tooth. The junctional epithelium provides a specialized protective barrier to microorganisms residing around the gingival sulcus. These collagen fibers bind to the attached gingiva tightly to the underlying periodontium, including the cementum and alveolar bone, and vary in length and width depending on the location in the oral cavity and on the individual. And then there's the interdental gingiva, which takes up the space between a tooth contact point, which is the space between two adjacent teeth. It's normally triangular in shape and is formed by two interdental papillae. The middle or center part of the interdental papilla is made up of attached gingiva, where the borders and the tip are formed by free gingiva. You also have the periodontal ligament, which is the connective tissue that joins the outer layer of the tooth root, being the cementum, to the surrounding alveolar bone. It's made of complex fiber groups that run in different directions and insert into the cementum and bone through what's called Sharpie's fibers. It's composed of mostly collagen fibers, but it does also house blood vessels and nerves within the loose connective tissue. When you bite down and you put a lot of mechanical force on those teeth, it's absorbed by the periodontal ligament. It acts like a shock absorber for the teeth. The alveolar bone surrounds the teeth and forms that bony socket that helps to support the tooth. It's that base layer, it's that foundational part. The cementum is the outer layer of the tooth, which overlies the dentin layer of the tooth and provides attachment for the collagen fibers of the periodontal ligament, and is typically a light yellow color.
Specialized periodontal exams are necessary to help us diagnose periodontal disease and help to determine the proper treatment course. A periodontal exam includes gathering the patient's dental and medical history, x-rays, and an examination of the teeth and tissues that support and surround the tooth. That's your periodontal charting. The periodontal pocket occurs when the gingival sulcus becomes deeper than normal, 1 and 2 and 3 millimeters, where the probe is able to go down beneath the free gingiva and next to the tooth surface is considered healthy. When we start seeing those 4s, that's where there's some inflammation, some gingivitis, that as long as our patient does a better job of flossing, it should resolve on its own. But then we start getting those 5 and above, and that's a lot more alarming because the gums are receding. The bone that is intended to support that tooth is now also being resorbed and can result in a loose tooth. The purpose of the probing is to measure how much of the supporting tissue has been lost to disease. Rule of thumb, greater the pockets, the more severe the disease. When periodontal pockets are present, they're nearly impossible for the patient to clean on their own. And if left untreated, the disease will only progress until that tooth is ultimately lost. There may be some early signs of periodontal disease, including gingival changes, inflammation, bleeding, and even a foul smell or taste coming from the gums. Periodontal disease is the leading cause of tooth loss in adults and has been directly linked to early term births, low birth weights, and has a strong correlation with Alzheimer's. There's also research that supports that if somebody has periodontal disease, it actually puts them at a higher risk for more severe reactions when infected with things such as COVID-19 and pneumonia. What that really boils down to is that your gum health actually directly affects your whole body health. What the hygienist does is they take their periodontal probe and probes around each side of the tooth. There are 6 measurements on every tooth, and as they go through and they call them out, you're writing or typing it in the patient's chart. You're going through in the 3 measurements. There are 3 on the buccal or facial and 3 on the lingual, and they're sliding that probe around each time that they're taking those measurements. Usually we're taking these more on our adults unless there's an indication that there's an issue with, like, say, a teenager. But I see a lot of offices that start about age 21 probing and recording these on the yearly.
Gum disease starts when bacteria begins to grow in your mouth. As it builds up from lack of brushing and flossing, and without treatment, it can begin to cause swelling, redness, pain, and eventually tooth loss. Almost half of adults aged 30 and older do have signs of gum disease, and about 9% of adults have severe gum disease. It begins with gingivitis. Gingivitis, itis meaning inflammation, is the swelling, redness, and bleeding in the part of your gums that's around your teeth. It's a more milder form of gum disease that can lead to periodontitis if you don't treat it, which would involve proper brushing and, more importantly, flossing in that case. When you forget to brush, floss, and rinse with mouthwash, that sticky biofilm of bacteria and food called plaque builds up around your teeth. That gunk then starts to release acids that are going to break down the outer enamel protective layer and can cause decay. After about 72 hours, the plaque hardens into tartar or calculus, and that forms typically around the gum line and makes it really hard to clean your teeth and gums properly. Over time, that buildup of calculus is going to irritate and inflame the gums, causing the gingivitis. As it progresses, you may end up with periodontitis, where the inner layer of the gum and bone begin to pull away from the teeth and form these pockets subgingivally. They can cause the teeth and gums to collect debris around them and become infected. And as the body's immune system begins to fight off the bacteria and plaque, it starts to spread and grow below the gum line. The toxins produced by the bacteria and plaque, as well as the body's good enzymes involved in fighting infections, start to actually break down the bone and connective tissue that hold that tooth in place. It starts to destroy the periodontium. Imagine taking a jackhammer to your foundation and just chiseling all the way around it on the outside wall and expecting the house to have good long-term stability. As the disease gets worse, the pockets deepen, and the more gum tissue and bone that's destroyed. When this happens, the teeth are no longer anchored and become loose, and the tooth loss does occur. This is going to be the leading cause of tooth loss in adults. But the good news is it's preventable. You can prevent or even reverse gingivitis if you brush and floss and have regular dental cleanings and checkups. There can be early signs of disease in the gingivitis stage where your gums may be red and swollen. They might even bleed when you brush and floss. We hear a lot of times patients coming in for their hygiene recall appointments that when we ask them if they floss, they say, well, no, because when I floss, I bleed. Well, what's really happening is you're bleeding because you're not flossing. Think of it like this. If you never exercise and you go in and you just hit a heavy day of CrossFit, you go all in, you don't take it easy, you don't stretch, what's going to happen? You're going to hurt. It's like flossing. You almost have to exercise the gums. As you're flossing, it gets them healthier and healthier and healthier so that that bleeding then stops. Now, there are cases where medications or other health conditions might be causing the gum bleeding or the inflammation, but in most cases it's not. You can reverse it if you step up that game because the bone is still in place. When we move into mild periodontitis, that's when that bacteria has gotten underneath there and it's gotten down to your bone. Your gums might start to pull away from your teeth and create these pockets, and the plaque and bacteria are going to want to fill those pockets to damage your teeth even more. Moving into moderate periodontitis, where it continues to eat away at the bone, and the gum continues to pull away. There may actually be pain with the patient's gums, and they may have pus around the gum line, which is a sign of infection. So there may be a pungent odor in the patient's mouth, or they might have a taste of like metallic sourness in their mouth, and that's going to be that bacteria. Advanced periodontitis is when there's severe damage, and in time that tooth is going to get loose, it's going to fall out. There are non-surgical procedures that we can perform, and there are surgical procedures that we can perform in periodontology to help keep a tooth healthy, potentially stabilize it. Now, we're not going to take a tooth that's completely mobile and grow that bone back up around it. There's no miracle grow for the bone. Once it's destroyed, we can get back a few millimeters, but in general, it's just to stabilize the tooth. And in some cases, we have to figure out, is this tooth worth trying to stabilize and probably not have a great result? Or do we need to extract this and consider other surgical routes to replace the missing tooth? After we've taken our readings, so those 1, 2, and 3 millimeters being healthy, 4 being inflammation, 5 and above is when we're moving into the mild, moderate, and severe periodontitis, we can take radiographs to also visualize and show our patients what's going on with their mouth below the gums. Comparing the digital radiograph on the left and the illustration of a radiograph on the right, the one on the right gives you some illustrations and writing that demonstrates the progression of periodontal disease from incipient to early to moderate and advanced periodontitis. You can see that calculus kind of stuck to the root surface and how the bone is resorbing. Compare that to the radiograph on the left, where you can tell around the premolar, that singly rooted tooth, that there's severe bone loss. It should be up around the cemento-enamel junction, that cervical neck of the tooth, is where that bone level should be. You can see between the molar how there's a furcation between the roots. There's that gap where there's no bone underneath the tooth. There are things that a patient does by their habits that can lead to gum disease, like not brushing, flossing, those sorts of things. But there are some things that are completely out of a patient's control that can increase their risk of gum disease, like hormonal changes that occur during pregnancy, puberty, menopause, and menstrual cycles that leave the gums more sensitive and make it easier for gingivitis to develop. Diseases like cancer, HIV, and diabetes increase the risk of infection, including periodontal disease. Some medications will reduce saliva production that protects your teeth and gums that can lead to decay and periodontal disease. And these drugs include ones that prevent seizures and ones that treat a type of chest pain. Smoking does make it harder for your gum tissue to repair itself. Just another reason why that can be harmful to the oral cavity. A family history of dental disease can also increase your risk of gum disease. You may have patients that come in that have done everything textbook-wise right. They brush, they floss, they rinse with mouth rinse, they don't have an overly sugary diet, they maintain a good amount of fermentable carbohydrates. But for some reason, even though they come in every 6 months, they're ending up with early signs of periodontal disease. It could be because of new medications or genetic factors and hormonal changes that are out of their control. And so what we have to do is continually check our patients because we want to get it in those early stages, those 4s and 5s. Because as it progresses, as you see here, we lose that bone structure. And we are not going to achieve 100% regeneration of the bone if they were going to go in and do surgical procedures to try and stabilize this tooth. Although the symptoms of periodontal disease can be hard to spot, there are usually warning signs. The most common being gums that bleed when you brush and floss, red and swollen gums, because healthy gums should be pink and firm, pain or tenderness in the gums, bad breath or a bad taste in your mouth that just won't go away, pain when you chew, sensitive teeth, pus between the teeth, receding gums that are pulling away from the teeth, deep pockets between the teeth and gums, loose teeth or teeth that are falling out, space between your teeth that look like black triangles, changes in the way that your teeth fit together when you bite, and in some people, it's not an across the board
every tooth scenario. For some people, it may only affect certain teeth, like the molars, where a lot of times patients aren't taking the time to floss properly. The only way to properly diagnose this in the early stages is through your radiographs and through your periodontal probing. As the disease progresses, it becomes more visibly noticeable, but only still diagnosed from a dentist or a periodontist.
All new patients and established patients that are adults should be receiving a yearly gum evaluation where the hygienist will take the periodontal probe and slide it underneath all of the buccals, facials, and lingual surfaces to determine the overall gum health. As they're sliding it underneath the gums, any 1, 2, or 3 millimeter readings are considered healthy. 4 millimeter readings are considered gingivitis, and then 5 millimeters and above is considered periodontal disease, which then we need to start looking into treatment of this oral disease because we know that it's linked to other overall health problems. The first procedure would be a non-surgical procedure called a deep scaling and root planing, or SRP. The scaling and root planing will consist of scaling all of the visible calculus off of the teeth with a series of hand scalers. After the hand scalers, the hygienist will then move into utilizing an ultrasonic scaler to help break loose any of the excess calculus. After all of that's been removed, then the root planing begins, where these scalers will be passed up underneath the gums and to clean off the surfaces of the roots. The scaling and root planing is going to be extremely therapeutic to the gums and tissues and will help encourage it to reattach to the tooth around it. Now this will be successful in regaining some of that pocket depth and making it shorter, but it won't take an 8 down to a 3. Now on to our first surgical procedure for the periodontic specialty. This one is rather non-invasive. It's not overly traumatic. It's pretty quick and easy. It's called a frenectomy. Frenectomies are where the frenulum is removed from either the lip or even beneath the tongue. The tongue, a lot of times, is because of tongue tied and it can create some speech impediments. But the patient will be numbed for this, and we can use either a scalpel, as we see here, or we can use a laser to carefully remove this tissue. performed simultaneously with the frenectomy is a free gingival grafting, where they're taking tissue from the palatal surface and transplanting it to the other area of the mouth. This can be done in conjunction with a frenectomy or in other areas when there's issues with gum recession. A procedure, essentially the opposite of dealing with gum recession, is when we need to perform a gingivectomy, where there's excess gum tissue, maybe because of braces or just the way that their tissue grew, but we can use scalpels or lasers to remove and lengthen that crown for aesthetic and functionality purposes. The periodontist will perform lots of different procedures, from frenectomies all the way through more surgical procedures like extractions, implants, and sinus lifts. We're kind of moving up in our degrees of procedures here. We're going to start off by viewing a sinus lift procedure. This is typically a tooth has been extracted and lost long prior to this procedure. The bone has resorbed in the area, making it very difficult for an implant to be placed, where if they did place an implant, it would most likely perforate the sinus cavity. They're going to numb the patient. They're going to make an incision in the gingival tissue, flapping it open to expose the alveolar ridge. Once the alveolar ridge is exposed, then they're going to make an incision in the side of the bone, essentially creating this little window where they will see the sinuses. They will elevate the sinuses, placing in a bone grafting material, and then the implant following. technician to draw blood and centrifuge it to help create a fibrin clot. This is a great way for the body to heal. It can be placed in after a sinus lift, an extraction, different surgical procedures, and that just helps the body to heal a lot better. And last year, we're going to watch an dental implant placement where they're going to make the incision, flap open the tissue to expose the alveolar ridge, and then they will slowly start drilling into the bone. They start with a pilot drill that slowly opens up that bone, continually increasing the diameter of the drill bit that they're using, and then later placing in the implant itself. The titanium implant needs to be carefully placed in at the proper torque, which is why they use the torque wrench. The guide pin in the radiograph allows us to determine whether or not we're drilling in the right direction, if we're at the correct depth. It kind of just helps us to know if there's any corrections that need to be made. As we slowly widen that bone, we're using that specialized implant handpiece, saline solution being sprayed directly into the surgical site, and us as the assistant suctioning and retracting. Continually taking x-rays to determine whether or not we like the direction that we're going for the surgery. And when it's time to place, we'll do so at a much slower RPM as to not break or strip the screw. And lastly, after it's been torqued into place, we are then going to place in what we call a healing head and suture it back closed. After it has a chance to osseointegrate for a few months, then they can put on what's called a impression abutment or impression coping. They'll take an impression of that for the lab technician to fabricate the crown to either screw onto the implant or be cemented onto the implant.
The specialty of endodontics, deriving from the Greek word endo, meaning inside, and odont, tooth, is the specialty that's going to deal with the study and treatment of our dental pulp. It's going to encompass the study of the basic sciences of how the pulp would be normal, the etiology and diagnosis, prevention, and treatment of diseases and injuries of the pulp, along with periradical conditions. Basically, it involves either preserving part or all of the dental health of the pulp or removing it in the case of irreversible pulpitis or disease of the pulp. It's one of the most common procedures, and if the dental pulp becomes diseased or injured, endodontic treatment is required to help save the tooth. Root canal treatment is the dental procedure that we use to treat an infected tooth pulp, which otherwise would be extracted. The pulp is the soft tissue core of the tooth that contains the nerves, blood supply, and connective tissue necessary for the tooth to be vital. Usually a root canal is caused either through trauma or deep decay. When the pulp is injured, it can have reversible pulpitis or irreversible pulpitis. Reversible is when you can do a pulp capping procedure, or it's something that, if you think about like a bruise, the tooth is in pain, it's throbbing, but the pulp is able to heal itself. When it's not able to and it continues and gets worse and develops infection, that's when a root canal for irreversible pulpitis would need to be performed. Prior to a root canal procedure, we do an examination through radiographic images, pulp testing that can be through percussion, so simply tapping the tooth, placing a thermal or cold stimulant, so putting on like a piece of ice or endo ice onto the tooth to measure the reactivity of the tooth. It could be hyperreactive. We call that a hot tooth, where the moment that you touch it to it, you're essentially in agonizing pain. Patients basically jumping out of the chair. Or the opposite, where it's a dead tooth, where there is no sensation to the tooth whatsoever. And we perform these tests to the adjacent teeth that are right next door, so we get a good gauge on what their normal would be. After that, and we've determined that it needs a root canal, we then isolate the tooth using a rubber dam. It's going to help keep saliva from getting into the tooth during treatment, and also protects the rest of the mouth, the airway, from these fine files and strong chemicals that we're using throughout it. We'll go in and we'll remove the infected and damaged pulp. We'll shape the root canal. We'll clean and disinfect the canal system, and then we will fill and seal off the root canal. In a endodontic office, the direct restoration, like the composite filling, is not being placed. They're placing the temporary restorative filling so that they can go back in a few weeks to their general dentist to have that done, along with either that and an indirect restoration, such as a crown. Sometimes instruments do fracture, meaning they break, like those small fragile files, and so it's really important to handle them carefully, check over your files and instruments to make sure they don't break, and then taking a post-operative x-ray just to determine that nothing was left behind. It is normal for a tooth to become discolored after a root canal, as we are removing the pulpal tissues. Another thing that a endodontist might be performing is periradicular surgery. This involves the root surface, including an apectectomy, which is the removal of the root end, root sectioning, which is the removal of an entire tooth, and the repair of an injured root due to perforation or resorption. An apicoectomy is a surgical procedure where the apex of the root is resected, the root end filling is placed, and it prevents bacterial leakage from getting into the root canal system from the periradicular tissues. It's used to help carry out this procedure through steps of microsurgical techniques. It can be carried out if a previous root canal treatment fails and that retreatment is not possible. They might have to go in a surgical step to take care of this. Complications might be pain, swelling, discoloration. Serious infection is really rare, but any infection typically is treated sufficiently with a round of antibiotics. Other non-surgical procedures that the endodontist performs is pulp capping, pulpotomies, and pulpal regeneration. A hemisection, where the tooth is overlying a portion of the crown, are separated from the rest of the tooth and optionally removed, where they're just taking out half the tooth, essentially. Through the use of magnification devices such as microscopes and dental loops, endodontists are able to perform microsurgical endodontics. It's believed to help increase accuracy and visualization in the operating field. As an endodontist, they will not only receive their years of training to become a dentist and pass the dental board, but they're going on for additional training. And in the U.S., that's usually about 2 to 3 additional years of postgraduate training to become an endodontist. The ADA programs are a minimum of 2 years in length. After they complete that training, they're eligible to sit for the American Board of Endodontology examination, and results in that diplomat status in the American Board of Endodontics. And although general dentists can perform endodontic treatment, there are several things that set these endodontists apart, such as using microscopes to better treat the small internal anatomy of the teeth without having to take away a bunch of the tooth structure. They also, a lot of times, use the CBCT scanning, the 3D imaging, to help assess the difficulty of the case and diagnose and treat the planning of those cases. In the case that a root canal instrument gets broken and lodged into the canal, an endodontist may choose to use an ultrasonic instrument to slowly widen the canal around the top of the broken off instrument. As they are going around and widening it, they may choose to use larger diameter ultrasonic instruments as they go. After they've been able to access more of that broken off instrument, then they can go in and remove the instrument, turning in a counterclockwise direction to essentially unscrew it from the tooth and remove it. We do want to make sure that this is removed so that there is no reinfection of the tooth to where they would have to have a retreat done to the tooth.
Procedure or a root canal therapy procedure, there are some common items that you're going to need, and the rubber dam is one of those. The purpose of the rubber dam is to isolate that tooth so that as we open up that pulp cavity and we're disinfecting it with the sodium hypochlorite, we don't have to worry about re-entering infection into that area. Another thing is when we are disinfecting, then we want to make sure that the disinfectant product we're using doesn't end up in the patient's mouth. So the rubber dam we'll see used in endodontics and pediatrics to help keep the tooth dry. They'll sometimes call it the trampoline or the rain jacket, or we'll even see it when we are replacing or removing amalgam fillings. Now the rubber dam comes in different thicknesses, in different flavors. Some of them are mint flavored. There'll be latex, non-latex, different colors. But they'll always have a powdered and a shiny side. So the powder side is the side that should be facing up towards the operatory light as to not reflect a bunch of that light. There are different ways to mark your rubber dam as to where you're going to punch it out. Sometimes they will come with these little templates where you will mark out on the full arch or just the area that you're working on. They may have you just marking the one tooth we're working on, which may be tooth number 3, or sometimes they will include 3 or 4 surrounding teeth in that rubber dam also. So we'll just go around and mark each of these just to give you an idea of what it looks like. So you can see here that we have our maxillary arch marked out, and we'll go ahead and we'll work on tooth number 4 for this endodontic procedure here. What you'll need is your rubber dam punch. Now this looks like a really big fancy hole punch. You can change the dials to be different sizes from anterior or pediatric teeth all the way up to those really large molars. So you kind of just pick and choose depending on the tooth that you're working on that day. Then you're going to find tooth number 1, 2, 3, 4 on our rubber dam. We're going to go to number 4, line it up, and punch through. So we can see here, it is a little difficult to see, but we can see here that number 4 is now punched through, and that is what the tooth is going to pop through here. Some doctors will have the clamps already preset in their rubber dam itself, and sometimes they will place it onto the tooth first and then stretch the rubber dam over top of it. The clamps that hold the tooth are different depending on what we're working on. So you may have an anterior, they kind of look like butterfly wings. A really common one would be a number 9. You may have a bicuspid one, which is a number 2. You may have a molar, which may be a number 7, which all of these little arches have the numbers imprinted on them. Some of them will have these wings on the side, and some of them are wingless, where this little projection is not there. There are 2 little holes on either side of the clamp where the rubber dam forceps is going to go into here in just a bit. This arch will always go towards the distal side of the tooth. So should be pointing towards the posterior of the mouth, and it should be arched away from it. So if we're looking at a maxillary tooth, no matter where it's at, this is how it should be oriented, where that arch is going posteriorly. On a mandibular one, the arch should be facing posteriorly and arching up from the tooth itself. Let's go ahead and start putting this on here. So we're going to orient this. We have to remember that this is our midline. This is towards the back of the mouth, so I want to put this in so that the arch faces posteriorly. I'm going to take this and I'm going to stretch that hole that I punched over top of those wings that I have on the dental dam clamp. Being careful not to rip the dental dam as we're doing this. This is what we have right now, is that's already in our dental dam. Next, what we can do is we can take our dental dam forceps that have these small little prongs on the end that fit perfectly into those holes. And this should go into where we can place it into the mouth comfortably. And as those in the holes, you'll notice that when you squeeze it, it stretches open that clamp so it can go up and over top of the tooth you're working on. So I'm going to squeeze as I'm placing this. So when you look here, tooth number 4 is what is popping and is isolated from the rest of the mouth. Like I said, sometimes we will include the teeth in front and behind. That just gives this rubber dam more stability to where it's not going to just pop out on us. Another little trick is I like to take some floss and tie it to my rubber dam clamp so that if it does pop off and it falls into the patient's mouth, I can easily just fish it right back out and we don't have to worry about that. We wouldn't want to just leave this like this because the patient's going to be getting it in their mouth. It's not helping to isolate and we really can't see what we're doing. So what we're going to be using is our dental dam frame. These frames are metal, some are plastic. They are U-shaped. The U is going to go under the chin and they are curved. So the curvature of the bow should go with the face. You start by hooking it on one of these little pins and then just crossing it across the frame until it's nice and tight, like a trampoline here. And that's what's happened sometimes is it does pop off the tooth, but you get the idea of where it's going to be placed if you are working and this is in the patient's face, like covering up their nose. You can either fold it up under or you can cut it around. But the idea is this is going to isolate the tooth.
This is a great animation of an endodontic root canal procedure. It's a lot better, I feel like, than watching just videos of a live root canal procedure, since with a live root canal procedure, you're not going to be able to actually see down into the tooth structure itself. We see here a tooth that has been decayed and the infection has reached the pulp canals. And so what we'll do is we will anesthetize the patient and go in and start removing the diseased tissue. This can be a series of different rotary instruments that are attached to the endodontic handpiece or hand files that are manually taken down into the canals, all the accessory canals, to clean and scrub it out. We slowly start to create a larger diameter in the canals so that we can seal off the ends, heating and compressing the material into each of the canals. We can widen thus again the canals a little bit more so we can put in retention pins that are going to give better stability to the composite filling that is placed into the tooth. We then will probably later go through, prep the tooth for a crown
so we can have a fully encapsulated and protected tooth. Preoperatively, we are going to take a periapical image. You can imagine how taking a bite wing wouldn't be sufficient in this case because we would not be able to see the apex of the tooth. After the tooth has been numbed and isolated using that dental dam, we can go in and start to access the pulp cavity. The dentist will go through, or the endodontist, with a series of different burrs to cut into the coronal pulp. Then they'll use their endodontic explorer to locate all the different canals, whether there be 2, 3, 4, and then the accessory canals are more easily located through the use of microscopes in the endodontic office. What they're doing is they're establishing the working length by placing the file down into the tooth to figure out how long that canal is. They then widen it with the Gates Glidden, disinfected, and are using the apex locator or radiographs. You can place those files down into the tooth to take an x-ray. And every time that file goes into the mouth, you as the dental assistant will want to make sure that it's measured to length. There is a little rubber stopper on each file that you will move up and down to determine the length of that file, using several different rotary instruments. Cleans and widens the canals. Irrigate with that sodium hypochlorite solution. Continually widen it. So these rotary instruments and hand files come in different lengths, but also different diameters. You wouldn't want to start with a really large diameter rotary instrument because you risk damaging the tooth irreversibly. You wouldn't want to use a large diameter hand file to begin with because you could break the file off in it, or it can be really difficult to get back outside of the tooth. The patient should not feel any of this. So if your patient does start to begin having sensation in the tooth at all, any pain around it, your doctor will then stop and re-anesthetize for their comfort. This is an image after the cones or the gutta percha has been placed down into the canals. They have not been sealed in there. They were just placed to take an x-ray and see their fit. They irrigated and are drying with these paper points. Look how clean and accessible those canals are. Now we place our gutta percha to obturate or fill. We may use an endodontic spreader or endodontic condenser to heat up and press down that gutta percha down into the canals. We want it perfectly sealed off. We want it pressed against the sides, stuffed full, so that no bacteria can reinfect the tooth from the tissues below. After all canals are properly sealed off, if it's in the endodontic office, they'll place a temporary restorative material, and that will be the end of your procedure. Another surgical procedure that the endodontist may perform is apicotectomies. It's necessary when your conventional root canal therapy has failed and retreatment is unsuccessful or just not advised. So what we're indicating here is that the root tip actually needs to be removed.
through state-of-the-art microsurgical techniques using operating microscopes, microinstruments, ultrasonic preparation. We're able to remove only the root tip, where in contrast, root resectioning is when we remove the entire root. And hemisectioning is where the root is removed along with the portion of the crown that's on top of it, separating it from the rest of the tooth without, optionally removing that one. This week during our clinical, we will have the opportunity to go through and practice for our final assessment exactly like we did for our midterm assessment, where we will get to practice through the clinical, we'll practice through some practice questions that you're going to see on the written, but so long as you've been studying with your Quizlet and you've been doing your weekly test as you have been required to, you will do quite well on this exam. Take some time to go through and review all of the second half of the course's content from week 6 all the way to week 10. The content that you're going to see is things that you're going to be assessed on. Now enjoy these next couple of videos that allow us to review some of those clinical skills that we can't simulate, but ones that you will see on the daily in a dental office. If you remember, dating back to the beginning of our course, orthodontics is the specialty that addresses the diagnosis, prevention, and correction of malpositioned teeth and jaws. We will go through some videos to see, again, how these are placed and what our roles are as a dental assistant. But also your oral surgery procedures, a panoramic x-ray is almost always necessary. When you place your patient into the panoramic machine, they're going to rest their chin on the platform and bite on the bite stick. If it's not a bite stick that can be taken off and sterilized, you'll want to make sure that you put the proper barrier on it. You have several laser lights that you can place on the patient's face to make sure that there's proper placement. The first being the horizontal ala tragus line, where it will line up with the tragus of the ear and the ala of the nose. The vertical laser light that we're adjusting is going to be the canine light so that we can line up it with the canine. Step away, trigger the exposure button, and have your patient stand still with their tongue pressed to the roof of their mouth. The machine will rotate around their head, taking a full exposure. Once it's completed the exposure, it will rotate back into place. Do not allow your patient to step out of the machine until it has rotated back. Patient and open up the resulting panoramic image on the patient's chart and have it open and ready for your doctor, making sure that it is perfectly parallel. There's no chin up or chin down in the image.